Good afternoon, everybody. I'd like to start by thanking you all for the invitation and for the wonderful weather. Unlike Brendan, I can honestly say I didn't bring the British weather with me. I gather the British weather, you're exporting this weather to the UK today, and we're very much looking forward to it. I had some fun yesterday texting my friends to tell them I caught the sun in Helsinki yesterday. I want to talk about something that is complementary to what Brendan's been talking about. A lot of the themes he's talked about are very relevant to the work we do and the work lots of people are doing in the UK. But I want to talk about an important issue that comes up in the circle of design that he was talking about, which is how do we pay for it? Where does the money come from? And in particular, how can the outcomes-based thinking approach that he touched on right at the beginning and the end of his presentation help make that happen? So I'm going to say a little bit, a very tiny bit about myself, so you all know why the heck I got invited here today and why I know a bit about some of these things. Again, very quickly about the challenge we face in the United Kingdom and perhaps compare that a little bit with other places. And how we think, because of the public service challenge, that looking at outcomes and particularly outcome-based management and commissioning can help us address some of those problems. How it works, how we think it might work if we can really get it to work at scale, and then talk particularly about some examples and challenges that we face in trying to make it work. I'm going to start with the very, very short piece about myself and my organisation. A4e has been around since the early 1990s, and it is a for-profit social purpose company which has major contracts in the United Kingdom, reflecting the way the United Kingdom has chosen to use the private and voluntary sectors to deliver a wide range of social type services. The business was founded on employability and is still very big in that area, so helping people who haven't got jobs to find work. But we're very active in other areas, training, offender learning, legal and financial advice, and an area that's very relevant to the aged theme of this seminar and this conference, which is helping older people use personal budgets, which, as some of you are probably aware, is a growing area of interest in the United Kingdom. We have 200 plus offices in the United Kingdom delivering a wide range of services, often from different offices for different services, which is something I'll come back to later, because we're not any more joined up than anybody else. And we also have a range of services around the world, particularly in Australia, but not in South Australia yet. And I come from the part of A4e that does research and consultancy, and in particular helps both external clients, particularly in government, and also the business I'm part of, to address these issues. And that has got us into major issues around service design, including co-design. But more importantly and more relevantly to what I'm going to talk about today, the issues of how outcomes-based commissioning and outcomes funding are a key part of the government's thinking and how it's trying to address the social challenges that it faces. I should say I'm also an escaping public servant. I was a civil servant for about 10 years before I became a consultant. So I have the similar sort of mindset of trying to understand them and help them make change. My last piece of introduction really is just to do some very crude and simplistic comparisons between Finland and the UK. The biggest single difference, I think, apart from the fact that clearly the UK economy is a good deal bigger, prosperity levels are very similar, I think. It's well known, I think, that Finland, along with other Scandinavian nations, spends more on public services than the UK does. The comparison there is, I suspect, closer than it's historically been. At 51% of public spending being GDP in the UK is far higher than it has historically been, typically more like 40 to 45%. And that reflects the recessionary conditions we've had and the need to spend more and the amount we spend on welfare. It's a common statement in the UK that we would like to have Scandinavian levels of public services and American levels of taxation, and we don't seem to be very good at achieving either. Social spending is, as one would expect, significantly higher, but the biggest difference, massive difference, I think, between the UK and Finland is the proportion of spending that, depending how you define it, can be defined as local. So over 70% of spending here is at local level, and it's almost the obverse in the United Kingdom. Particularly with health spending being centralised and most welfare spending being centralised. Only under 30% of spending is local, and we would not have an equivalent of your deputy mayor in the UK who has responsibility for both health and social care. I want to move on and talk very briefly about some of the challenges we face. I suspect most people are tediously aware of the United Kingdom being very proud of its approach to trying to reduce its deficit. I'm not going to get into the politics of that or whether it's a good or a bad thing. I do want to make 2 points about it. The first is that the blue line shows, ignoring the fact the scales are slightly different, if the blue line shows we are asking those relatively small proportion of our services that are local to take a much bigger hit and to take it much faster than the national services we provide. And the second is that the overall reduction we're making, the red line shown there in real terms, is relatively modest, but it is in fact a steeper cut than has ever been achieved in the United Kingdom. This graph shows the total we spend and have spent broadly since the Second World War and since the formation of the post-war welfare state in the United Kingdom. I suspect many countries have a similar graph, but why I think that's important is I think the debate has got very polarised in the United Kingdom in the last couple of years between a government that's perceived to be making extremely radical cuts in spending, and it's kind of masking a longer-term issue, which is, in common with most developed economies, the demand for public services in the UK is ever rising. It's ever rising because of demographic factors, some of which have been touched on already, and because of expectations. People expect better public services all the time, and it's very difficult to reverse that cycle, which means that those who are thinking ahead and not just thinking about this year's problem in the United Kingdom and elsewhere are saying, how do we get those services radically changed and transformed in the way that's already been discussed so that we can make more of the resources that we've got? And just to make the point, this is nowhere near as good a graph as the Deputy Mayor had, but it's making the same point. The old age dependency ratio in the UK is set to decline or change rapidly. But I was surprised to find that Finland's is the fastest deteriorating in Europe, but not as bad as the EU average. And it's the southern European economies that are the most challenged on that and the ones with the greatest problems, as we know already. But clearly, it's a major challenge for all economies and one of several that are not easily solved without radical change. I want to touch on some other issues which are not just about how we get more out of the money we've got in terms of its total, but about how we shift the balance in what we do and how we do it better. The first is, it's been acknowledged for some time that we don't spend enough on prevention in the United Kingdom, that most of what we spend is on crisis services. Again, this is not uncommon. But only 4% of our health spending is on preventative services, and that represents a doubling of resources in the last 10 to 15 years or so. So it was even worse before. And although there has been a shift in the balance in old people's care towards home care and away from residential care, and that's something that we want to do more of. We want to do more of it both because it's what users want, both because it's what people themselves want. They want to stay in their own homes. And also, it's quite simply much more cost-effective to keep them in their own homes. It isn't happening as much as people want, and we still spend nearly 3 times as much on residential care. One of the prime reasons for that is that many of the local authorities that are responsible for social care in the United Kingdom have invested heavily in residential property. They have residential homes that they need to keep full. So although the change that most people want, and there would be more cost-effective, is to home care, the balance in most places is in residential. 2 more issues I want to talk about before we move on to some of the solutions we've been looking for. Services in the UK are very poorly joined up, and because of the split between central and local, they're poorly joined up in 2 different ways. First is the familiar scenario of having lots of different silos, different stovepipes in which particular services sit. And the second is a very poor join up between services that are provided centrally and provided locally. And the one I'd highlight, above all causes of problems, is the poor join up between healthcare and social care. So we have our national treasure, the National Health Service in the United Kingdom, which is the 4th largest employer in the world. I'm not sure whether we're proud or apologising for that when we say it, but it is a very centralised service, our biggest consumer of public funding, and it is very centralised service. But social care, care for the elderly, care for disabled adults, care for children, is provided predominantly by local authorities and is the biggest consumer of resources locally. And as long as I've been involved with public services, which is too long, I care to remember, nearly 30 years now, people have been talking about the need to join up social care and healthcare better in the United Kingdom, but it hasn't been achieved yet. And there are some other areas of very poor join up, for example, between training and work support, key areas for my company and for the economy as a whole. They're commissioned by different departments, they're paid for by different departments, and they should logically be much better integrated. And that lack of integration has a major impact on service users who have to go to many different places to get the services they need. And our involvement in co-design and our involvement in the sort of techniques that Brenton talked about at great length shows that to be a major, major issue. People do not know where to go to get help. Where they do go to get help, they find they've gone to the wrong place. They find when they get help, they have to be assessed again and again with almost identical requests for data and requests for information to what's needed. And most importantly, I think, from our point of view, as one of the people who's in this system and provides services, and ours are just as unjoined up because of the sort of contractual relationships we're put into, is poor sequencing of interventions. So people can't get help in the order in which they really need it. An example I often give is people who come looking for help with unemployment and because of the situation they're in, may be facing eviction. They may be facing eviction from social housing. If they're in that situation, we will be unable to help them. We would not be able to help them with that problem, and we'd have to refer them somewhere else. But until that problem is solved, there is really very little we can do for them. There is no way that most of the customers we have are going to take much, are going to have much time and interest in solving the issue of finding work until they solve the immediate issue of having nowhere to live. Because if you've got nowhere to live, the problem will be even worse. So that's a range of issues, some of which are directly about how we pay for things, and some are about how we design services to make them better fitted to both citizens and to those who are grappling with the problems of making these services much better. And the role of outcomes-based thinking in that, I think, is a number of things. The first is it comes back to the issue that Brenton talked about right at the beginning and the end. It forces people to say, what are we trying to achieve here? What are the outcomes we want? What are the outcomes users want? What are the key problems that we have to address? Not, how do we do what we do now a bit better? The second is that by opening that approach, you enable to think more innovatively and about different ways that they can design things. And the third and fourth are much more directly related to the financial aspect. The third is, if we get this right, we think we can achieve at least a degree of self-funding for the outcomes that we want. And by providing those additional resources, we can help the process of moving resources towards early intervention and away from prevention and solving that problem. So let me say a little more about the models and the way that these have been addressed. The next part of this, I think, is a very simplified description of some quite complex issues, but I hope it will come across fairly clearly. I'm happy to talk, obviously, at any point in the subsequent discussion about any of the issues raised. Sorry, I moved away from mine. The most basic model, commissioning for outcomes, commissioning and requiring anyone who provides a service to think about outcomes, has been around for a long time. In a UK audience, when I give similar talks to this, I asked the question, when people think payment by results, which is what we sometimes call this process in the UK, was invented, and people tend to guess something like 1990. It was in fact invented in 1861, when the UK, the then Board of Education in the UK introduced payment by results for certain degrees of teaching and skills, particularly the teaching of the 3 R's and needlework for some reason. I don't know why, needlework. But so it's been around a long time, and it is not a new thing for people to say, we want the results to be what we commission and what we pay for. The second thing I want to say about that is that it doesn't have to be a commissioning process. In the UK, I think there are so many people getting locked into the idea that this can only be done through a process of external commissioning, using the third or private sector to deliver services. But in fact, the process of identifying outcomes, managing those outcomes, and expecting people who deliver services to focus on measuring their performance against those outcomes can be done without that commissioning process. And the principles are relatively straightforward. As Brenton has already identified earlier, focusing on outcomes says, what do we want to achieve, not what do we do now? And it opens up a much more radical agenda for the people providing and commissioning services. And for the provider, providing things are put in that way, they can think very differently about how they can deliver the service. But it's important, I think, that people don't try to do both. We found many examples in the UK, people saying, we want to commission on outcomes, we want to focus on outcomes, but then they hedge that around with an awful lot of inputs and processes and saying, you must do it this way. And that clearly limits the opportunities for the sort of radical design people are looking for. And if it is an external model, a key advantage, as we see it in the United Kingdom, is that the payment is made for those services when the outcomes are achieved. So where it is aligned to an outsourcing model in the UK, we do see it as a way of transferring risk to providers, but clearly that isn't always the model that's being aimed at. Where it gets a bit more interesting, and where I think we moved on, so we certainly didn't have this thinking in 1861. What we had in the mid-2000s was changes, particularly starting with support for those seeking work and extending into other areas, and I'll talk about a bit more in a little while, of saying, if we get this right, if the outcomes that we achieve truly are much better outcomes and address some of the major social challenges we face, then they should at least be part funding. And Brenton again referred to the concept of the business case and working out the social impact of what's achieved. So on this model, the commissioner works out really at the start how much they're likely to be able to release in funding from the outcomes that they achieve, how much better things will be financially as well as socially from the changes that are made. And at least in part, ideally in whole, those reduced costs will fund the payments that need to be made to do things in a different way. And in the most radical model that's being attempted in some areas, the UK is using external investment to make that happen. Investment either from the providers themselves, who have to provide their own working capital to make this happen, or investment from a third source. I don't know how relevant some of that will be in the immediate future to those in other countries and in Finland, but certainly we're getting very excited about it in the UK. In fact, some would say we're getting too excited about it in the UK, and in other places like Australia, who are trying to copy the model because it's at a very early stage. But it has opportunities. Personally, I think we need to be careful about how much we can do that, and we also need to be careful about where we do that, and we also have to be careful about moving too fast with something that hasn't been properly and rigorously tested. But it does have opportunities. And in the longer term, and in some of the areas where I've been working with my team in the last year or so, we see this is an opportunity to go further, to not just look for simple commissioning of simple outcomes, but to use it to drive what's often called co-commissioning of complex cross-cutting outcomes. So use it to break down some of those silos and force people to work together to deliver the joined-up services and commission those joined-up services. which in turn drives a much more transformative approach to the delivery of those services. In particular, services that get round some of those sequencing issues and some of the overlaps for individuals and for families, because you'll find we'll be coming back to families in a few minutes. So that's the model, and that's how it basically works. There are many variants on that being developed at the moment. There are many different ways people are thinking, both in terms of public funding public services and public funding private and external services, about how they make that model work. I just want to pick up on a couple of examples. The first example, and the biggest, so I can't really avoid it, is what's called the work programme in the UK. This is the current government building on the previous government's efforts to pay for people to find others work, what's often called active labour market policies. It's much the biggest programme we have in the UK of its type. It has an estimated value of about £5 billion, €6 billion or so. Whether it actually gets to that size depends on how successful those delivering the programme are, because it is based on outcomes and their achievement. So if they aren't achieved, then it won't have that much value. But it's interesting that the whole point of the programme is to be successful, not to fail. I make that point because it's frequently debated in England that because the risk has been transferred through the commissioning and outcomes-based process to providers, it doesn't matter if it succeeds because they've got the risk. But it does matter enormously to government. They would much rather it's successful and they had to make the payments than it failed. It also pioneered, it doesn't mention it on this slide, but it also pioneered very much the outcomes-based approach to innovative design, what's often called in the UK the black box approach. So the processes and delivery mechanisms that people use to work with the workless that come to them needing help vary enormously and are very much their business. There are minimum controls on what they have to do, but there are far fewer controls than there were on past programmes in the United Kingdom. The government has said, and the policymakers have said, we really want to focus on what works, and we will pay for what works. We did not care deeply about how you achieve those things. There are a number of examples that I'm not going to talk about today, but could talk about separately, that focus on the offending area. The Ministry of Justice is very interested in offender rehabilitation, and that's an area where some external investment is being used. But the examples I want to talk about a bit more, apart from the work programme, is secondly, drugs recovery. The Department of Health in the UK is funding local health partnerships which bring together local authorities and what are called primary care trusts in the United Kingdom, basically the commissioners of primary health, to focus on solving the major challenges around drug misusers. And two things are interesting about this. The first is that it is the use of public money funding other parts of the public sector, but in a way that forces them to work together much better. So bringing together some of the services that have been traditionally been provided by local authorities around housing and around some aspects of public health, which is their responsibility, and the services that have tended to fall almost entirely on the health service in the UK around actual treatment of drug users. And the second thing that's interesting about it is that the outcomes have been set are broader. So it isn't just about getting people clean in the jargon, getting them off the drugs that they're using, but also about looking at the secondary impacts that has, particularly on their offending behaviour, since there is an extremely high correlation between casual drug users and Class A drug users in particular, and low-level crime, burglary and robbery in particular. And obviously their improved physical health and the impact that might have on both mental and physical outcomes for them. That's at a very early stage, and it'd be interesting to see how that goes. The reason I say that is it's going to be quite interesting to see how they will measure those secondary outcomes. And I want to move on to the area where myself and my team have been most involved in last year, which is an entirely different aspect of troubled families. So while Brenton was designing what sounds like a fantastic service in Australia, working with other families, we've been working with local authorities in the UK with the troubled families problem we have, to look in particular at whether the improved outcomes for those families can be made self-funding, either through external investment or from better investment and better design of the services that are provided to them. And this is where it gets very challenging. Challenging for a number of reasons. One, that the outcomes are numerous, which means that the measurement of those outcomes becomes extremely complex. And challenging because the government is both putting its own money into this from the central pot, but is expecting in return quite tight measurement of the outcomes that it wants, rather than necessarily what's desired by local authorities. And on top of that, local authorities have to provide their own resources. So let me say a little more about that. This, I apologise for the complexity of this slide. It's a much simplified version of what's actually happening. But essentially, central government is putting in 40% of the funding needed to address what it calls the troubled families problem in the United Kingdom. This is designed specifically, and with quite a political bent, I think it's fair to say, to turn around an estimated 120,000 troubled families in the UK who have poor outcomes for themselves, have poor lives for themselves, and are estimated to cost the economy something like £7 or £8 billion a year. I don't want to go into the days. There's actually a lot that could be said about the whole troubled families issue in the UK, because it's become quite complex between those who are saying these families need a lot of support and those who see it in a much more pejorative way, that these families have brought their problems on themselves. But suffice it to say, the government is committed to providing help, but that help has come with quite significant strings. So the central government departments at the top, Education, Work and Pensions, Ministry of Justice, have put up funding, but that funding has been linked to some very specific outcomes. The concern for local authorities is two things. One, those aren't necessarily the outcomes they really need to address. And the second is that in order to address the problems, and this is where our work has been very focused, they need to join up a significant number of interactions at local level. The biggest single problem in this area, undoubtedly in the United Kingdom, as it is in Australia, is children going into care. It has a very high fiscal cost, as Brenton has already said, and despite efforts in recent years to reduce the number of children in care, it is in fact at its highest ever level. I've been working with one council, Birmingham City, admittedly a very large council, which has more than 2,000 children in care in one local authority in the United Kingdom. So where this comes together is that the local authorities themselves have to find 60% of the funding to make this happen. So what they've had to think about is both how they design the service differently and how that can be turned into a way of paying for the service. This next slide looks at one of the real programs that have been the result of that. This is a representation of what's called the Family Recovery Programme, which is run by Westminster City Council in London. It has some similarities to some of what Brenton talked about. I think it's fair to say there's been less family involvement in the design of it. Certainly, families are heavily involved in the process of deciding how the Family Recovery Programme works with them, but it has had more top-down design. But it has similar elements. The most important thing about it from the point of view of the local authorities, two things. One, they've managed to get contributions from a range of other providers in the local area. And this is one of the biggest challenges we face. Local providers who are not in the local authority have been very reluctant to put their own funding into this sort of support. And importantly, it brings together adult and children's services within the local authorities. So some of the problems we face are not only about services being joined up between agencies, but even within the local authority, adult services and children's services tend to be separate. There are historical reasons for that, but in fact, after 20 years of trying to separate the two, we're now trying to put them back together so that we can manage families. And these are some of the real results that have been achieved in that program so far. So 4 children at risk of care have avoided going in. There's been nearly a 50% reduction in antisocial behaviour, a significant reduction in eviction, and a very substantial fall in offending behaviour and arrests. All of that is calculated to have saved the council a good bit of money, or I should be more accurate and say it has avoided future cost. And this is where it becomes a bit more challenging for them. I'll come back to that in a few minutes, but essentially they know that they are avoiding an increase in costs, but unless they can change the way they actually provide the services now and switch some of them off, it won't actually reduce the costs that they spend and release money for more services. So in order to make this work, and in order to make the measurement of outcomes work in relation to families, we've had to address a major step up in complexity from what we've seen before. Excuse me. In areas like employment and offending, we've been tending to measure one relatively straightforward outcome. Are people out of work now in work? Are people who were offending no longer offending? There are some complexities around that. Obviously, we are also looking in some of the offending pilots that have been trying to measure reductions in the severity of offences committed and the frequency of offences committed. But in families, we were looking at a different level of complexity. In one of the councils we've been working with, we found 33 factors that one of the councils wanted to work on with families. So one of the key issues is that every family is different. We found that in one family, you may find 6 or 7 factors, such as child at risk of care or child offending, child excluded from school. So the problems heavily focused around one child, perhaps. But that could be because a mother is misusing drugs, a father is out of work. In another family, the problems will be very different. In the third family, they'll be different again. In the fourth family, they'll be different again. So in areas of this level of complexity, new approaches are needing to measuring the outcomes and how they're delivered. And it means that we need much better data than has ever been available before in order to make this happen. There are basically 2 approaches that we've been trying and make this work. The first is to break that total cohort of families down into the specific risk factors that they face, to say, can we brigade families together into certain factors? That works technically, if you like, top down. People say, yes, we can make that work and we can achieve the measurement that we need. But frankly, in other ways, it doesn't work. They don't come in neat little boxes like that. And all the authorities work with say that isn't what we want. We need a whole family service, and all the benefits of this come from working with families in a holistic way, not in working with them in that fragmented way. So what we've been looking at is how we can manage the risk across a much larger group of families and say, these are the key things we want you to achieve. If you achieve those things, then we know that we will get a substantial payback on our investment. We know that the outcomes achieved will reduce costs hugely, and we will be able to reflect that in the way we fund it. But we also know that we'll be able to achieve the sort of holistic service that's required. I want to finish by talking about some of the major challenges we face in making this work and how we're trying to address them. Some of these challenges have come up with the recent focus on payment by results and outcomes commissioning, but some of them are around from other initiatives in the UK. We've had an initiative a number of years ago called Total Place, which was about combining resources locally and saying how can they be used to best effect and how can we avoid some of the duplication and overlaps that exist. More recently, we've had an initiative called Community Budgets, which tries to achieve much the same thing at a slightly more local level. In fact, Community Budgets failed and has been replaced by what's called Community Budgets 2, rather like a software upgrade. We're hoping Community Budgets 2 is more successful than Community Budgets 1. It's been designed slightly differently, but a personal view is it won't solve the underlying issue, which is that most of the top-down providers of service find it very difficult to think outside their own self-interest about these things. Some of the initiatives we've seen and some of the ones we've been involved in have had some success in that area. The Westminster one in particular has managed to get police resources into it, but that's rare. But there is a growing school of thought in government in the United Kingdom that they might have to grasp the nettle and make it happen. So it will be a degree of yet more centralisation, unfortunately, to make that happen. But effectively, government will take a slice out of everybody's budget and put it into a common fund that will help to move this along and make it happen. It will be interesting to see if the government floats that idea, because I suspect all the same providers who've resisted sharing will also resist having the money taken away from them. And it may come back to them being, eventually they'll be able to come to a better accommodation if that's achieved. I was actually out with Jussie and a few guys last night, and we had a very nice meal where we had to split the bill 11 ways in order to satisfy everyone's requirement and it took longer to split the bill than it did to eat the meal. And I think it's some of the same issue. But in fact, if 11 people eat a meal in a restaurant, there's no reason why they can't agree to split the bill between them. So, the second challenge is what technically is often called decommissioning, a euphemism really, or a techie word for saying stop doing things. In order to do these things differently, in a world where funding is not infinite, then we have to stop doing some of the things that we already do. And this is extremely challenging. Again, we've found an enormous amount of what's technically called often called status quo bias in the UK. People saying, we'd rather stick with what we do now, however much we might want to change it and do it differently. And the aforementioned Charles Ledbetter has just released a very good report suggesting some ways that might be achieved. But in a sense, it's similar to the issue of top slicing and co-commissioning. Frankly, we confront people's self-interest of saying, I don't want to change the way it's done now, and I certainly don't want to stop delivering services if that puts the jobs of individuals at risk, if that puts my budget at risk. There are some ways it might be done, but again, the government is saying we might have to do it for others. We might have to take the money out of crisis intervention services and put it into more preventative services in order to make some of this happen. I don't have a clear view on that one, but it's interesting to have some debate with the people in this room about how it can be achieved. I think that is possibly the knottiest problem of all, of how you actually move things along, particularly in a time of financial constraint. Lastly, I want to come back to make the point that everything I've said is about a different level of the same thing. We are very interested in co-design in the UK, and in particular, we've been pioneering personal budgets, both as a way of driving user involvement in the services they receive, and as another form of effectively outcomes-based commissioning. We see two forms of payment by results in the UK, the type where a commissioner pays a provider to do it, and a type where simply the user of a service becomes a customer, and they have the power to decide how that service is provided. And in doing that, we're using many of the same techniques. And in particular, we've been doing some work with drug-using offenders in Hammersmith that I haven't got time to go into today, but there's very much on the same focus of involving users in the services they receive. I want to finish by just talk about where we think this will go. In the UK, we think outcomes-based, or certainly some of us, me included, think outcomes-based commissioning is already at a crossroads. Some people are saying, this is fantastic, this will solve all our problems, this will mean that in the future we can create virtuous circles of saving money from better outcomes, and everything will be hunky-dory. At the other extreme are people who say, it's a fad, it will be gone in 2 years, it will achieve nothing. I'm in the middle. I think it does have significant opportunities and value, and I think that if it's done right and it's done carefully, then it will have major impact on the way we provide the services we do and the amount of money we're able to reinvest in better services. In the short term, I think it will grow fastest in areas that are relatively straightforward, where it's already been invested, such as work. And I think we've done very little in the UK to look at the area that's central to this seminar, adult and old people's care. As I said earlier, we're not spending enough on domiciliary care. And every day in the UK now, practically there is in the news is a story about the crisis in social care that we face. But no one is looking at the obvious point that if we could spend more on cheaper services that keep people in their homes for longer, we could help to solve that problem. The normal reaction from both right and left in the UK is we have to find a way of finding more money, either from the taxpayer or from cuts elsewhere in services to pay for it, not about how we can recycle the money better. As I've said, I think unless we get more cooperation between providers of services, who at the moment find it very easy to say, it's not my budget, I'm not paying, the government may grasp the nettle and say, we will do that for you. And I think they will also allow that much more to the use of co-design and personal budgets in the longer term. Some of the councils we've been working with are already saying we can have personal budgets for families. The whole family could have the money they need to turn their own lives around. So it'll be interesting to see where that goes. I am. Thank you very much. We'll take questions later.